Hey there, future nurses. Welcome to this study guide explainer. We designed this specifically to help you lock in the absolute key concepts from chapters 8, 17, and 19, so you can walk in and completely ace your week 3 quiz. I know, nursing school is super demanding, but today we're going to break this material down into clear, visual, and highly testable chunks. We're pulling straight from Dr. Kuykendall's course materials, so you'll be totally prepared.
All right, let's just quickly glance at our agenda for today. We're covering 4 main areas. 1. Clinical cues and assessment. 2. Navigating chronic illness. 3. Age-related vision changes. And 4. Age-related hearing changes.
Starting right off with Section 1, Clinical Cues and Assessment and Gathering the Right Data. Okay, time for your first knowledge check. I want you to think about how age-related sensory changes should impact your physical environment. What's the best approach when obtaining a health history from an older adult? Are we grabbing a private room, bringing in a family member right away, raising our voice, or just taking thorough notes?
And the correct answer is choosing a private, quiet area in a comfortable room. The whole idea here is that a private, quiet space minimizes sensory overload, which really promotes accurate self-reporting from your patients. Actually, simply raising your voice can distort sound for older adults, and immediately relying on a family member, that kind of strips away your patient's autonomy. Remember, setting up your physical environment is literally your very first nursing intervention.
Now, when you're doing that physical assessment, you might use what's called the clock drawing test. It's a highly testable and incredibly reliable tool for evaluating a patient's executive function. Along with things like the mini mental state exam and the mini cog, asking someone to just draw a clock face can really quickly reveal early signs of cognitive decline.
You also absolutely have to memorize the SPICS acronym. It's your go-to framework for spotting common geriatric syndromes. SPICS stands for sleep disorders, problems with eating or feeding, incontinence, confusion, evidence of falls, and skin breakdown. Keep this front of mind, and you won't miss the big issues during a comprehensive assessment.
Moving right along to Section 2, Navigating Chronic Illness and Managing instead of Curing.
So here's a massive shift in mindset you need for the exam. You have to understand the difference in your nursing goals here. Acute illnesses are sudden and generally curable, right? But chronic illnesses, they progress slowly, they cause severe fatigue, and they require lifelong management. You aren't trying to, quote-unquote, cure these patients. Your interventions are going to focus entirely on symptom management, preserving their energy, and preventing severe complications.
Now, obviously, we're aiming to promote ideal, healthy aging behaviors, stuff like healthy diets, staying socially connected, and getting routine screenings. But you need to watch out for the flip side. When chronic conditions or sudden hospital trips overwhelm a patient, sensory overload can set in. And that doesn't just look like confusion. You really need to be on the lookout for severe agitation, emotional shutdowns, random outbursts, or even patients trying to physically elope, escape from the facility.
All right, here's another knowledge check straight from Dr. Kuykendall's slides to test your grip on chronic disorder risk factors. Look at these behaviors. Which one of these is placing an older adult at risk? A BMI of 22.1? Walking for 30 minutes? Smoking half a pack? Or eating fruits and veggies?
If you guessed smoking half a pack of cigarettes per day, you hit the nail on the head. As a nurse, our primary goal in chronic illness management is reducing modifiable risk factors. A BMI of 22.1 is perfectly healthy, and walking or eating veggies are protective. But smoking? That is a massive modifiable risk factor. You really want to focus your patient education on things they actually have the power to change.
Let's jump into Section 3, Age-related vision changes, seeing the difference.
Let's start with a really important vocabulary term, presbyopia. This is a structural vision change. It happens when the eye's lens literally loses its elasticity, and you usually see this start between ages 45 and 55. Because the lens just can't easily change shape to accommodate or focus on close-up objects anymore, patients are going to need interventions like bifocal lenses or reading glasses.
Now, whatever you do, do not mix that up with presbycusis. Presbycusis is an inner ear sensory neural hearing loss. A good trick is to notice the cusis at the end. Think acoustics. This issue makes high-pitched sounds, especially rhyming consonants like S or TH, incredibly hard to distinguish. It also makes filtering out background noise a real struggle. Make sure you've got presbyopia and presbycusis completely straight before exam day. Got those definitions locked in? Good. Let's tackle a question about cataracts.
What's the chief clinical manifestation you'd expect in the early stages? Is it eye pain, floating spots, blurred vision, or diplopia? Double vision.
The correct answer is blurred vision. Here's what's happening. Cataracts cause oxidative damage to the lens, and that leads to opacity or cloudiness. Because that cloudiness stops light from passing through properly, the early signs are things like blurred vision, decreased night vision, and seeing halos around lights. Also, a huge key differentiator for your test is that it's generally painless in these early stages.
So what are your actual nursing actions for aging eyes? Well, standard bright hospital lighting can actually make things worse. Instead, you want to use warm incandescent lighting and try using yellow to amber lenses to really cut down on glare. Oh, and for discharge planning, always ensure their educational materials are printed in large, dark print with sharp contrast. I mean, they need to actually be able to read their discharge instructions, right? That brings us to our final section, Section 4, Age-Related Hearing Changes, comparing conductive versus sensorineural.
Time for another quick knowledge check, this time on assistive devices. What information should you include when teaching a patient about a new hearing aid? Does it amplify and direct sound? Does it work better in noisy rooms? Does it interpret sounds? Or does it bypass damaged portions of the ear?
The right answer is A. It amplifies and directs sound into the ear canal. The mechanical distinction here is absolutely crucial. Hearing aids simply make everything louder. That's actually why option B is wrong, because they make everything louder, they can make noisy, crowded rooms overwhelming. Now, if a device is actually bypassing the damaged ear portions to directly stimulate the auditory nerve, you're thinking of a cochlear implant, not a hearing aid.
So how do we actually communicate effectively with hearing-impaired patients? It's not just about yelling. Remember presbyhusis? High-pitched sounds are the first to go, so you need to consciously lower the tone or pitch of your voice, speak at a moderate speed with careful articulation, and don't just crank up your volume. Also, keep your hands away from your mouth so they can read your lips, and definitely make sure you have their attention before you start speaking.
To wrap things up, I want to leave you with some food for thought right before you head into that quiz. Why is it so important to understand how pharmacodynamics impact our older adults? Think about everything we just covered. How might sluggish kidneys and a chronic illness, or cognitive changes, or sensory decline completely alter how a drug is metabolized and utilized in the aging body? Keep that clinical judgment super sharp, study hard, and best of luck on your Week 3 quiz. Future nurses, you've got this.